Good day, I'm Dr. Candice Fick from Wits RHI, University of the Witwatersrand, Johannesburg, South Africa. I'm here to present to you an analysis we've done from programmatic data emerging from 2 high HIV burden metropolitan health districts in South Africa. I would like to acknowledge PEPFAR and the CDC who have made this work possible. Among older persons over the age of 50 years in South Africa, the HIV prevalence in 2021 was 13%. This number is expected to rise to 24% by 2030. Non-communicable diseases in South Africa have a high prevalence, with common non-communicable diseases including hypertension, diabetes, and hypercholesterolemia. As the numbers of older PL-HIV on ART continue to grow, as the expansion of ART increases, HIV will increasingly become comorbid with other chronic diseases. And so we've asked ourselves the question, what is needed for 95-95-95 for older people living with HIV? What is important for integrating planning for the fourth 95, maintaining a high quality of life while managing the associated challenges of aging with HIV? To profile the potential scale of this challenge, we analyzed 95-95-95 program performance data for 2 high HIV burden urban metropolitan districts in Gauteng, South Africa. Wits RHI receives funding from PEPFAR to support routine program implementation within these 2 high-burden metropolitan districts. The Tshwane Health District and Ekurhuleni Metropolitan Municipality Health Districts are 2 of the most densely populated districts within Gauteng as the most densely populated province within the country and the second highest burden province for HIV. Age and gender disaggregated data were extracted from Datum as the routine program reporting platform for PEPFAR for a 6-month period from October to March 2022. These data were analyzed according to current MER indicator definitions in use by PEPFAR. This slide summarizes indicators and definitions used for the analysis done on this routine program data. Older people living with HIV were defined as people 50 years of age and older. Retention in care was measured at 28 days of the last scheduled appointment. Treatment interruptions and returns were measured per quarter, as was mortality data. And viral load coverage required at least 1 viral load test conducted within a rolling 12-month period for patients on ART for more than 6 months. Viral load suppression for the purposes of this analysis was set at 1,000 copies per ml. Overall, these were our findings for the 6-month period across the 2 districts. There were 760,000 HIV tests done for the 6-month period across these 2 districts, of which 6% were conducted for people over the age of 50. There were 539,418 people living with HIV in care, with 23% over the age of 50. And of these, 74% were aged between 50 and 60 years old. Additional analysis here presented as an HIV care and treatment cascade. When looking at HIV testing, as reported, we had 45,327 tests conducted for people over the age of 50, of whom 3,344 were newly diagnosed as HIV positive during the time period. This translates to a 7% positivity rate, which is significant as the usual positivity rate seen for the program overall is around about 4% in this context. There were 2,737 new ART initiations in people living with HIV over the age of 50 during the same time period, which roughly translate to about 82% of the newly HIV positive diagnoses. In terms of retention, we saw the number of older people living with HIV increase by 6,772 for the time period observed, a rough increase of about 6% to a total cohort size of 125,173. I'll discuss this more in additional detail on the next slide. In terms of viral load management, 83% of eligible people over the age of 50 had a viral load done, and of these, 96% had a suppressed viral load. So while we do see high rates of viral load suppression in alignment with literature published in other countries, there is a severe challenge in terms of access or completion of viral loads as needed by patients in this context to ensure that we are able to adequately measure performance towards 95, 95, 95. Just to touch on the retention piece again, I think it is important to note that this is a dynamic cohort with a great deal of movement seen into and out of the cohort during the time period. As promised, a little bit more detail on the movement into and out of the cohort seen during the time period. As mentioned, we saw an increase in the total number of older people living with HIV of around about 6%. This was contributed to by new initiations onto treatment, aging into the cohort, returns to care from patients previously lost to care, as well as transfers in from neighbouring districts and regions. When we looked at interruptions and returns to care, both were measured as snapshot measures per quarter, here reported for the October to December and January to March quarters separately. We see that there were a great deal of interruptions for the October to December period, and just under 3,000 interruptions seen from January to March. At the same time, through return to care interventions and spontaneous returns to care, we saw 2,341 returns to care between October and December, and 3,600 returns to care between January and March. There were 300 deaths reported during the 6-month period, but to note, these deaths were from all causes and not specifically related to HIV. So to conclude, this analysis has found clear gaps in the HIV treatment cascade for people over the age of 50 living with HIV. Most notably, these gaps have been seen in linkage to antiretroviral care and treatment after the HIV diagnosis, as well as for patients accessing viral load testing to ensure that we can measure viral load suppression towards achievement of 95, 95, 95. Among older people living with HIV retained in care, most were 50 to 60 years old in this cohort. And to note, there is a potential for increasingly complex healthcare needs as their age increases. The need for tailored programmatic planning is apparent, as is the need for more research to guide targeted interventions for older people living with HIV in this context and within the rest of sub-Saharan Africa. Thank you very much for your time and for your attention. I would also like to thank my co-authors at WITS-RHI, at CDC South Africa and CDC Atlanta, as well as the conference conveners for the opportunity to present.